This presentation is on the high ankle sprain, also known as a syndesmotic sprain. A syndesmotic sprain is a sprain that occurs proximal to the ankle joint and affects the ligaments that connect the tibia to the fibula, as seen in the photo below. This is an uncommon injury. It's estimated that 6,445 syndesmotic injuries occur in the U.S. per year. In a study done in 8 states, there were 2.09 syndesmotic injuries per 100,000 people. Syndesmotic ankle sprains account for 11 to 17% of the ankle sprains in athletic populations. This slide reviews the anatomy and mechanism of the injury. These injuries are frequently variable and often poorly recalled by the patient. They typically occur due to an external rotation of the foot, eversion of the talus, or excessive dorsiflexion. They can also occur by a twisting or rotational injury. Individuals who participate in skiing, football, soccer, and other turf sports that involve planting of the foot and cutting may have the greatest risk for ankle syndesmotic sprains. The high ankle sprain involves 3 ligaments. It involves the posterior inferior tibiofibular ligament, the anterior inferior tibiofibular ligament, and the interosseous membrane. This is another picture of the 3 areas that are affected most in a high ankle sprain. Once again, you can see the 2 tibiofibular ligaments and the interosseous membrane. The medical diagnosis is detected when the patient has pain proximal to the ankle joint, tenderness over the deltoid ligament, or when the patient describes the mechanism of injury. Several authors have suggested that isolated syndesmotic ligamentous injury is rare and is usually accompanied by a lesion of the deltoid ligament and fibular fracture. The gold standard of the diagnosis is a radiograph. Anterior, posterior, lateral, and mortise views are used to evaluate the syndesmosis widening. As seen in the last bullet point, tibiofibular clear space in the AP and mortise views should be less than 6 mm with an intact syndesmosis. As always, radiographs should be taken according to the Ottawa ankle rules. The Ottawa ankle rules are as follows. Bone tenderness along the distal 6 cm of the posterior edge of the tibia or tip of the medial malleolus, or bone tenderness along the distal 6 cm of the posterior edge of the fibula or tip of the lateral malleolus, or inability to bear weight both immediately and in the emergency department. CT, MRI, or arthroscopy may be necessary if patients have persistent symptoms following a syndesmosis injury or if a clinical diagnosis is still uncertain. The following are signs and symptoms found in a high ankle sprain. First, pain and tenderness located primarily on the anterior aspect of syndesmosis and interosseous membrane, possible tenderness over the lateral ligaments, painful active and passive external rotation of the foot, swelling and bruising may be minimal or late in appearance, and swelling may also be found at the midline of the foot. Within the physical examination, the therapist may find positive findings with 2 special tests. The first is the squeeze test. The patient is sitting in this test and the therapist squeezes the upper to middle third of the leg. A positive for a syndesmotic sprain is pain in the distal third of the leg. The second special test is the external rotation stress test. The patient is in a seated position with the knee flexed to 90 degrees. The therapist stabilizes the lower leg and internally rotates the tibia while the ankle remains in neutral and then externally rotates the foot. A positive for a syndesmotic sprain is pain over the anterior inferior talofibular ligament. A third test you may hear about is the cotton test, but this is more commonly used in the emergency room. the cotton test will also be positive. Conservative treatment is recommended for patients with syndesmotic sprains in the absence of a fracture. First, we're going to cover the medical and surgical management. The patient should be non-weight bearing and immobilized for approximately 2 weeks. The patient should be on crutches or a walker, and it is imperative to prevent further talar or fibular rotation, as well as further disruption of the syndesmotic soft tissues. Next, there's the physical therapy management. There are 4 phases that range from the maximal protection phase through the patient's return to activity. This is a table representing the conservative treatment options with the syndesmotic sprain. The chart is divided up into the 4 different phases based on the patient condition. For example, phase 1 is a maximal protection phase. This is when the term RICE is used, which means rest, ice, compression, and elevation, and the therapist should avoid stretching the ankle into dorsiflexion. As you can see from the chart, it covers also phase 2, 3, and 4, and you'll see descriptions of the specific types of interventions that can be performed. This slide covers the prognosis of the high ankle sprain. It does require a longer recovery time than a lateral ankle sprain, and it also increases the likelihood for future ankle sprains. There are a few complications that can occur. There can be increased stiffness within the ankle. With surgery, there could be infection or injury to the nerves, specifically the superficial peroneal nerve. And arthritis is possible in severe sprains if the cartilage is also damaged at the time of the injury. The following are various types of outcome measures that can be used with a patient with a high ankle sprain. The first is the foot and ankle ability measure, which is a self-reported scale for activities of daily living. There are 2 subscales, one for ADLs and then one that is sport-specific. A score of an 8 or a 9 on the subscales distinguish patients that have improved versus non-improved after 4 weeks of physical therapy. The Foot and Ankle Disability Index is an expanded version of the Foot and Ankle Ability Measure. The Foot and Ankle Disability Index is another measure with 2 subscales. The FADI has 26 items and the FADI Sport has 8. The third outcome measure we have listed is the Lower Extremity Functional Scale, which includes 20 self-reported items assessing activity and participation. The MCID is 9 points, and this score of 9 within 24 to 48 hours and also at week 2 distinguishes those that are expected to improve from those expected to not improve.